Welcome, everyone. We're super excited to have you all join us this afternoon. I'm Scott Kennedy, Executive Director and co-founder of Solving Kids Cancer. We're very proud that today's discussion is presented by a collaboration of nonprofits. We all share a deep and dedicated commitment to helping children and their families with both the cure as well as the care and support parts of impacting childhood cancer. We invite you to look into the missions of each organization to learn more. Putting aside COVID for the moment, most of us here are first and foremost people who are experiencing or have experienced life as a cancer family. So normal life is already anything but normal. Secondly, on top of this, we have the pandemic to deal with. So we're hoping to address and discuss topics that are clearly relevant for our community, where we're facing both of these dimensions all at once, and it can be overwhelming to say the least. Getting back to the COVID dimension, right now we're at an inflection point in terms of the pandemic, and this is lining up with many of the normal changes we see at this time of year. Back to school, changes in work and home commitments, planning for the end of the year and the beginning of the next year. So we feel it's important to have a check-in and air out what's on people's minds. We really want to share what's on your mind today, so let's get started with our discussion. Please submit your questions for any of the speakers or for the group through the Q&A that you'll see at the bottom of your Zoom control. You can do that anytime through the discussion, and we'll coordinate those questions and they'll be answered at different sections and at the end of the webinar. If some of the questions aren't addressed due to time constraints, we'll get them answered offline and we'll follow up on email with the responses. Also, the webinar is being recorded, so an archive will be made available and we'll send an email to you afterward. Just want to say we're very pleased to have Dr. Jeff Auletta join us again as a presenter. Dr. Auletta is the director of the Host Defense Infectious Diseases and Bone Marrow Transplant programs at Nationwide Children's Hospital. Also, Rhonda Ryan, a licensed master social worker and director of the Family Support Program at Friends of Karen, an organization that's been helping families for over 30 years. Additionally, we're pleased to have Kim Buff, founder and executive director of Momcology, a group who've really pioneered the way to utilize community as a superpower to support families. And finally, our friend Jonathan Agan, who's a leading advocate in the childhood cancer community and an executive director of the Max Cure Foundation. So without further ado, I'm going to turn it over to Dr. Auletta to get things started. Welcome, Dr. Auletta.
Great, thanks, Scott. And thank you everyone for joining, and thank you for my co-leads on this seminar. All right, so I have roughly about a 20-slide presentation that I hope will be helpful for establishing some foundational understanding for the group that has joined us today. So the first thing I want to advocate for are proper online resources to actually get the best information from. Certainly the pandemic, as we all know, has created a lot of angst, mainly because of the changes that are inherent to a pandemic. In other words, the information changes quickly because the pandemic itself changes quickly. But these are actually the three best places to find good information on the internet, and that is the World Health Organization, the Centers for Disease Control and Prevention, and then I have here Ohio Department of Health. That's your local Department of Health is actually helpful. So when we talk about COVID, this is the CDC website updated today, and it's in retrospect for the last 24 hours. The number of cases in America is truly astronomical in terms of about 5.8 million. The total deaths is surpassed 175,000. The number of cases, as we see in the lower right, have diminished. In other words, the surge, the second surge, as you will, has definitely been higher than the first surge in terms of total cases per day. But certainly the amount of deaths has dramatically increased as well. And the second thing is testing. So you might have heard about in the last 24 hours how the CDC has made a judgment call in terms of not testing asymptomatic people, and how that has kind of stirred up a little some controversy in terms of that. But of the data that we have through the CDC in terms of the total number of tests that the CDC receives, the actual prevalence of the virus based upon that positive testing is roughly 9%. So 9 out of 100 tests are actually positive for COVID. Now, there are some limitations to that, right? It's all dependent upon how many tests the CDC gets. In addition to that, some of these tests can actually be the same individual who is positive twice. So again, this is data that we have. It's limited by its limitations, but nonetheless, it's the best source of information that we have. The other thing that you've actually probably heard about on the news is Middle America right now, and the cases increasing potentially versus the rest of America. And this all has to do with the changes over time of viral prevalence in the community. So when we talk about COVID, I think there needs to be a level of understanding of what that actually means. So this is a cartoon. Again, I don't expect anybody to be jotting down all these details that I go through, but hopefully it's a pictorial representation, and sometimes pictures are worth 1,000 words. So there's this virus called SARS-CoV-2. So this virus actually attaches itself to the respiratory epithelium. So what does that mean? So in other words, the respiratory epithelium is inside of our nose and down our trachea into our lungs. It literally has these projectiles or villi, these hairs. And the reason why we have hairs in there is because we don't want a lot of stuff to go down into our lungs. So the virus literally attaches itself through one of its spike proteins. That's why it's called coronavirus, because it looks like a crown. These spike proteins, and they attach themselves to the respiratory epithelial cell, which has this special receptor called ACE2. So that allows the virus to literally invaginate itself into that cell and then deassemble and reassemble and leave. So we talked about this in our first seminar. Viruses are parasites. They can't replicate without some kind of cell to go inside of and disassemble and reassemble. So the first is the virus. The second then is the immune response to the virus that makes COVID-19 detrimental. And what I mean by that is we all have an immune system, right? And if we didn't, we'd be overcome by a lot of different germs in our environment. So our immune response mounts an inflammatory response against these germs. In this case, for adults who have chronic conditions like diabetes or hypertension or pulmonary lung disease, they actually have baseline inflammation to begin with, because that's what these chronic diseases instigate. And so now this virus comes on top of it, makes an acute response, and that's what causes severe COVID-19 in adults. In other words, you and I, because we're older, our immune system has seen a lot over our lifetime, and therefore the amount of chronic inflammation as an adult increases in the background. So when there's a new novel virus like SARS-CoV-2, our immune system wants to attack it, but it does it at a higher set level than a child. We'll talk about that in a second. And then lastly, it has to do with what other things are instigated in the context of inflammation in our body. So the inside of our blood vessels themselves are actually responsive to viruses. And that's what's called endothelium, not epithelium in our trachea, our windpipe in our lungs, but endothelium in our blood vessel. So once that endothelium is activated, it causes this robust hematologic response to occur. And that's why people have often gotten thromboses or blood clots in terms of COVID-19. So it's the virus, it's the immune response to the virus, and it's other cellular responses to the virus in our body that causes severe COVID-19. So what does that look like? As a clinician, we do what are called CT scans. That's up at the top. And this big fluffy stuff, that's called alveolar opacities. And also there in the background here is what's called ground glass opacities. So this is the heart, this is an airway, and the airways in our lungs are like our highway, our road systems in America. You have the highway, you have a main road, and then you have the side streets. So the same thing happens in our lungs. You have these main windpipes, you have these secondary windpipes, and then you have these smaller windpipes. And what happens is you ultimately get down to these air sacs. So this is what an air sac or a alveoli looks like. Literally, it's one cell thick. And that's where gas exchanges occur. So you breathe in oxygen, we exhale out carbon dioxide. So you want there to be that, maintain that singular layer without a lot of stuff inside of it. Look what happens with SARS-CoV-2. So this is a severe inflammatory response where you actually lose that architectural structure of that alveoli, that single cell layer. And now on the inside, it's no longer clear, but it's all this gunk. It's all this inflammation that appears. So that's what makes severe COVID-19 detrimental. That's why adults who have severe COVID-19 are on ventilators, because they can't get rid of this stuff. And it actually doesn't allow the lungs to expand properly and exhale air. So when we talk about the SARS virus, again, what does SARS stand for? Severe Acute Respiratory Syndrome, Coronavirus 2. And COVID-19 is coronavirus disease 2019. So again, this is what the coronavirus looks like. I tell you what, in terms of viruses, this thing's in the driver's seat. Why is it in the driver's seat? Well, the first thing is it's easily transmissible. Now, if you watched any kind of the news networks, they mention this R naught. That means how many people, if one person has it, how many people get it. And right now, it's if one person has SARS-CoV-2, or roughly about 3 other people get it. So it's pretty easily transmissible. However, it's not as transmissible as measles. Measles, one person gets measles, 12 to 18 people that one person comes in contact can get measles. So again, it's pretty transmissible, but not as transmissible as measles. The other thing, it's hardy. That's why you have to, the recommendation is to clean off common touch surfaces. So in other words, countertops or laptops or keyboards, both in the workplace and at home. Lastly, there are a couple other things rather. There's no good antiviral medications. Yes, we have remdesivir, but remdesivir is like Tamiflu in terms of the duration of the disease. Tamiflu, it basically knocks off 2 days. Same thing with remdesivir, and actually it knocks off 2 days of severity of having the virus. So it doesn't eliminate it, it just decreases the amount of days of having the virus. And then the other thing is we don't have a human immune response because this is the first time our bodies are actually seeing the virus. So we have nothing to rely in terms of getting rid of the virus. And this is where it comes into vaccinations. We'll talk about that in a second. So again, based upon these principles of the virus, that's why we're told about wearing a mask and socially distancing, so we actually can decrease the exposure that we have to the virus. That, again, you've also heard on the news about asymptomatic carriage. That's trying to contain the virus within your mask so you don't spread it to other people. Staying at home if you're sick or been exposed to COVID, and washing your hands often because, again, the common surfaces. So this is what we're dealing with at multiple points in our country, right? We're overwhelming our healthcare system into places like New York initially, Washington in terms of Seattle, Houston, Phoenix, LA. And again, if we just implemented these simple public healthcare policies, we probably wouldn't overwhelm our healthcare system. So next, I want to kind of get into some hot topics that are relevant in terms of pediatrics and public health in general. The first thing I want to talk about is what happens to kids with COVID-19. What have we learned so far? And also specifically to the pediatric cancer patients. When is a vaccine coming? We all heard the news about, billions of dollars that our government is spending and well worth the investment in terms of vaccination. Return to school, right? I know that's a big topic with a lot of people on the seminar. We'll talk about what that means and what to consider. What does the future like with regards to SARS-CoV-2? And I could be honestly with you, I see the foreseeable future measured in years. I don't see it in months in terms of this virus. It actually can become the new influenza where we kind of get a yearly vaccine in order to protect against SARS-CoV-2, but we'll have to see. And then what should I do differently for my child? We'll talk a little bit about that as well. So first topic is, COVID-19 in kids. What do we know? So a lot of detail here, but I kind of want to go bullet point by bullet point. The first is in an immunocompetent, in other words, a child who has a normal immune system, The vast majority of those children, as defined by age less than 18, get very mild COVID or asymptomatic COVID. But for those kids who are less than 2 years of age, they have the highest rate of hospitalizations. So roughly about 25 children less than 2 per 100,000 kids in general get hospitalized versus 8 children per 100,000. So what does that mean relative to in adults? In comparison to the adults, rather, roughly 165 adults per 100,000 are being hospitalized right now. So again, this veil of protection that kids have, we'll talk about what that means. The other thing is that kids, despite not being hospitalized, they certainly have high viral loads, and they could shed the virus in their nose and in their fecal material as well for weeks after getting COVID-19. So despite having a high virus and despite shedding the virus for a long time, the kids actually have mild disease. In addition to that, children can infect adults. That's typically what happens with respiratory viruses, right? We all know in terms of if we have kids, if they go to grade school, for example, they catch influenza, they actually bring it back in terms of the house. So some lights here, in other words, some silver linings, some positive news, right? Because I think we need to focus on positive news when it's there. And that is the third bullet point, that most immunocompromised children either have not had COVID-19 or they experience mild to moderate infection. So despite their immune system being compromised, this veil of protection that kids have against COVID-19 still remains intact. And that probably has to go back to that immune response that we talked a little bit about. In other words, kids are at a set point different than adults. So they don't have this chronic inflammation in the background. So when they get a new virus, their immune system doesn't overcompensate for that virus. I think a second thing that differentiates kids from adults are those endothelial cells. They don't react against the virus as robustly as an adult does. So in other words, they have decreased risk of all those secondary complications of COVID. So the other thing that people have shown is that ACE2 receptor, that the receptor that the virus attaches itself to in the respiratory epithelium, kids tend to have lower levels of that. So the virus can't attach itself and replicate. It can't be a parasite in terms of kids. So some of these are theories, some of these have been shown, but again, it probably contributes to that veil of protection that I mentioned before. However, kids are not necessarily immune-free. So there's a syndrome called multi-system inflammatory syndrome. I know that's gotten a lot of attention in the press, and it should, but we have to think about that relative to the prevalence of disease in kids. And what I mean by that, it's a very rare complication when you think about the number of kids exposed and who have had COVID. It usually occurs about 2 to 4 weeks after COVID and manifests with certain symptoms, particularly with regards to the heart. So the next focus will be actually vaccines. So this has drawn a lot of attention, right? Because we went over, we don't have an immune response. So the way that we want to get an immune response is by vaccinating. So we certainly want vaccines to be safe, right? We want them to be tested. We'll go through in terms of what phase 1, 2, and 3. And this audience, I'm sure, is very well educated in those phases of clinical trials. We'll talk about efficacy, being that we want the vaccine to be immunogenic, in other words, to stimulate a proper immune response and memory for that immune response. Again, the whole world needs these vaccines, so you have to talk about manufacture to scale, right? And that's going to take more than one vaccine, more than one drug company in order to do that. And then distribution, right? You have to think about everybody across this planet. All those people who actually live in rural and not very well accessible areas in the world. And then we want this vaccine to induce herd immunity. And we'll talk a little bit about what that means in the next slide. So herd immunity. So this gets into, we want the increase of people we want people to get the vaccine so there's an increased amount of protection in the community. And this is just a pictorial representation of that. So this yellow figure of a person here is an immunized, healthy individual. When you don't have any of those people in the background, everybody's susceptible. That's what we currently have right now. And so therefore, people get sick and contagious. They become red. When you have a couple people in the background who either have gotten the disease and mount an effective immune response or actually receive the vaccine, you have less of a chance of or risk of spreading the infection among the community. When you have a lot of people who've actually received the vaccine, then there's a very low risk to the community. So that's the herd immunity that we want to talk about. So what are some of the impediments to herd immunity? Well, the first is you need a vaccine, right? You need it to be available, safe, and effective, just like we talked about. And you have to have manufactured to scale. You have to have enough of this vaccine. But the bullet point or number three is not inconsequential. And that is you have to have a willing public to receive the vaccine. And this gets into wearing my general pediatric hat here and my infectious disease hat. Not everyone gets their child vaccinated, right? That's why there's a measles outbreak in New York that we've actually recently seen. So these three things have to come into play in order for us to develop herd immunity. And I think a lot of this has to be consistent messaging, right? I think we have to have consistent messaging from the federal level, the state level, and the community level. Because if there are mixed or cross messaging, I think that impacts the public's willingness to actually get vaccinated. So this is just a pictorial representation of herd immunity. Various studies had said roughly around 60 to 70% of the population. When you look at places in the world where they've actually done antibody testing of people who've actually gotten or background of COVID-19, you can see in various spots in the world we're far from herd immunity. So that's why we really need this vaccine to come into play. So vaccines educate the immune system. Well, how does it do it? So again, a little pictorial representation here. Don't expect everybody to become an immunologist here, but to let you know how it works. So scientists come up with a vaccine that actually can stimulate the immune system. So they inject it into lab animals, and then they actually do phase 2 studies, and then ultimately into phase 3, what's going on right now with the Pfizer vaccine here in America, for example. So what happens is you inject this into the body, you actually stimulate B or boy cells that are producing antibodies, but sometimes you need T or Tom cells to actually help out the B cells. So what happens is you develop a robust immune response and a memory for what that vaccination was, so that when you come in contact with it in the future, you actually mount an immune response to that. So this is what this actually looks like. So you have a primary response, which occurs either with primary antigen exposure. So that's, in other words, what's stimulating your immune system. That could either be a vaccine, or it actually could be what you normally encounter in the environment. So that the next time that you experience that vaccine or that encounter with the germ, you mount a higher immune response. So I have right here, actually currently I'm involved in or I'm participating as a subject in the Pfizer study. So what happened is I got an immunization about a month ago, and then I got my second immunization yesterday. I don't know, it's blinded. I don't know if I received the vaccine or not, but I certainly had a lot of side effects in terms of the second injection. So I could surmise that my immune system was primed with how I developed some that second injection. But that's the whole point. I believe the SARS-CoV-2 vaccine will be a 2 injection vaccine. You'll probably get 1 injection and then a secondary to mount a higher immune response. So we talked a little bit about the development of vaccines, or I want to talk a little bit about that. So I think the first thing is, is altruism, right? I think we live in a country where altruistically people want to do the right thing. Sure, we're talking about billions of dollars here, but in the end, in order to manufacture a vaccine to scale to that degree, you really need a lot of money in order to do that. So I don't want people to think, oh, the pharma industry is like pumping it out right now, right? I mean, $9 billion, thinking about the hundreds of millions of vaccines that actually need to be there. And some of these pharma companies have actually said they're going to have no charge to the vaccine based upon reimbursement from the government. So how does this all work? So the first, and again, I think that this audience is very familiar with this. The first is preclinical testing in animals. Typically that takes years, right? And then you get to clinical testing. Phase 1 is looking at maximum tolerated dosing. Phase 2 is looking at, do you get a response that you want? And then phase 3 is it safe and efficacious in terms of a grand scale? So again, normally this process takes years. So right now we're months into this, and there are trials right now that are phase 3 for SARS-CoV-2 vaccines that have literally spanned months in order to get to a phase 3. So I think that there are 2 good articles I suggest people to take a look at. One is out of USA Today, which goes into the distribution of income across these pharma trials. The other is by Pete Reinstein. He actually wrote a great commentary on why it actually is advantageous to live in America based upon the system and the infrastructure that we have with regards to novel discovery as well as therapeutics based upon the industry. So putting these viruses and these vaccine candidates into perspective. So there are vaccines that use dead virus to stimulate the immune system. There are vaccines that actually use just the DNA or nucleic acid of the virus, in this case, RNA. And there are vaccines who use other viruses to actually kind of tag along and instill that into the body in order to mount an effective immune response. And then lastly, there are vaccines that actually use certain proteins. All of these vaccines, you will not be able to get SARS-CoV-2. They're all inactivated. None of these are live viral vaccines. So just like influenza vaccine, it's inactivated. Despite having some symptoms, those symptoms are probably more related to the immune response to the vaccine or the response to how the vaccine is actually developed in terms of mediating immune response. So the other thing I want you to pay attention, this is actually really kind of cool, to be honest with you. It's called the Coronavirus Vaccine Tracker from the New York Times. You can go every day, this was updated today, and actually see the number of vaccines that are different phases. And actually this puts it into perspective. So there are certainly vaccines that are here in America, and there are certainly vaccines that are being, that are being tested all across the world, right? Because that's what we want to do, collectively eliminate the virus. So this is the vaccine that actually people have heard a lot of Russia. So I'm in no position to scorn what's going on in Russia, but that process in terms of vaccine development, that's what's in the news right now. A lot of those steps, a lot of the data sharing hasn't really been forthcoming in terms of from Russia. So that's where some of the questions come in terms of vaccine safety and efficacy. So flipping over to school.
Could I just
Sure.
interrupt just a second? We have a few questions coming on in the Q&A box that I think pertain to this section a little bit, if you don't mind. So we have a question from Aaron Kennedy. He's wondering if there is any data on children currently in treatment and having a positive COVID test and how that outcome has been.
Yes, Aaron, great question. The answer is yes. So there have been several publications, both in China, Europe, and America, that kids who have actually contracted COVID have actually, in general, done fine. There are certainly those kids who actually, for lots of different reasons, for example, if they were in a certain phase of their treatment, therefore their immune system was lower and not able to contain the virus, then went on to the intensive care unit. But even those kids who go to the intensive care unit, the majority of those kids actually get back to the floor. But there is a certain percentage of kids who have actually not done well in terms of COVID. But again, that percentage relative to kids in general and relative to a cohort of other immunocompromised kids actually are on par with that. So yes, there are kids who have died from COVID, unfortunately, but the vast majority of them, including cancer kids, either have mild disease or are asymptomatic.
Great. There's another question from Denise Velasquez. She said, what is being done to ensure the vaccine will be safe to administer on such a large scale? What would you say to the folks who want to defer getting the vaccine until it's been administered a couple of years?
Yeah. So Denise, I think that's a great question. And as a parent, you have the ability to not vaccinate your child if you so wish. But I think this gets back to what I mentioned here in America. You know, these vaccines have gone through phase 1 and phase 2. They've just gone into acceleration. In other words, they've gotten to the point where they've tested them in animals, and then they've tested them in several hundreds of patients in order to get to a phase 3. This Pfizer trial that I'm involved with, and even other phase 3 trials, are literally 30,000 people. So those will be helpful trials to know about safety and efficacy in order to vaccinate yourself or your child. So 30,000 people is a pretty good number. So I think there should be some confidence in a phase 3 trial that's done correctly and involves that large number of patients. I do think, though, those 30,000 patients, there's not going to be, for example, pediatric cancer patients. Now, what I mean by that is I'm not worried about them contracting the virus from these inactivated vaccines. Matter of fact, that's why we give the flu virus vaccine to all of our kids who have cancers or bone marrow transplants that I perform. The issue is, are they going to mount a protective response because they're, whatever phase of chemotherapy or therapy that they're in? Will their immune system reactivate against that vaccine in order to mount that protective antibody response? That's what is going to be questionable. But I think the vaccine should be safe enough to give. The question is, for our patient population on this webinar, are they going to mount an effective response against the vaccine?
Great. And I think we'll take one more question right now. We did just want to let everyone know that Dr. Auletta has graciously agreed to answer some of the questions we may not get to during the time allotted offline, and we will be able to send those out to you with the answers post-webinar. So one more from Michael Post. If a child is in treatment for T-cell lymphoma, does that T-cell involvement limit the impact of a vaccine?
Yeah, great question, Michael. So I think I would first say it depends upon what phase of therapy the child is in. So T-cell lymphoblastic lymphoma or leukemia, obviously induction, and then they go on to various other phases, as I'm sure you're well aware. I think maintenance is probably a point where there will probably be an immune response. I think in induction, for example, or consolidation, there probably won't be as an effective immune response. But again, Michael, without having done the studies in those kids, in T-cell lymphoblastic lymphoma kids, it's really hard for me to give you a concrete answer. I kind of go back to my other response that I gave to Denise, and that is, I think the vaccine will be safe. The question is, what will be the effective immune response to the vaccine? Anything else, Kim?
I think we'll keep moving forward, and then we'll get back to some questions in the next section.
Okay.
Thank you.
So I know this is a huge topic right now. Return to school, right? Well, we want our kids, father of 4, we want our kids to go to school for lots of different reasons. Quite frankly, some of them are just to get out of the house, to be honest with you. But there are other reasons for that. I think we all know that school is very important, socially, academically, culturally. So school is a good thing. The problem is we're in a pandemic, right? And then you kind of get some of these news items that come along, and how do you put all this stuff into perspective? Well, the first thing is, I believe that there are helpful websites. So the American Academy of Pediatric put out a policy statement. Again, they strongly advocate that kids go to school. I think this caused a little bit of fury in the community. Media picked up on the fury, and the rest is kind of history. So I think that we want to put this statement and this policy in perspective. inherently there's nothing wrong with going to school. That is what this policy said. The other thing that this policy was saying is, based upon the background that I gave you, the vast majority of kids actually do fine with COVID-19. So knowing those two things, that's where this policy came into play. Now, does that cover every one-off? Of course it doesn't cover every one-off, but that's kind of the message and the crux of the policy. So as you probably know right now, that in terms of looking at either your child with cancer or his or her siblings who want to go to school, and you're trying to make that decision, should they go to school, there's lots of different things out there on the internet. This is again from the American Academy of Pediatrics, to actually look for in schools to make sure that schools are doing the best that they can to decrease the spread of the virus. So these are just little basic checklists that you have. On the CDC website itself, when you click on these, you get to other sections of the CDC website or a PDF of this information. This too is good information to have, both on the AAP and the CDC website. In fact, the CDC website looks like this. So again, if you just Google CDC coronavirus, you'll get to this primary website. And if you click on schools and childcare, you'll get to the schools and childcare programs page. And then it goes through the various things that I think are very helpful for parent caregivers. So it goes through things in terms of what the school should be doing, how they should be operating during COVID, questions that you have in terms of, as a parent, should my child go back to school? I think this is a very helpful website in addition to the AAP website. And again, this in terms of, as a school administrator, you can kind of click in and get an inside view of what school administrators should be actually looking at as well. So checklists, I think there are lots of them, but in terms of the AAP and the CDC, those are probably the two information sources that I think are good spots to check out checklists for returning back to school. So I wanted to highlight 3 studies that kind of got out there, and then people were like, why is the AAP saying go back to school when these bad boys came out? So the first thing is the association. This is a study that came out of Cincinnati that actually looked at the association between school closure and COVID incidence and mortality in kids. So what this study did was, based upon looking at epidemiology or epidemiologic data, they were able to extrapolate that the number of cases and pediatric mortality decreased based upon the closure. Well, that makes sense, right? Because you're decreasing the exposure of pediatric patients. So if you decrease exposure, that's beneficial because they're not going to get virus. So that was the main crux of this study. I think it kind of got used to show that going back to school is dangerous. So I think, again, what was the actual message and what is the new message that people put into that? I think another issue is this one coming out of Georgia. I think people have heard about this, where there are pediatric patients who went to an overnight camp. Some of them were positive for the virus. They spread it to other kids. The moral of the story here is, yes, that definitely happens. The reason is because they're not very good implementations in terms of those public health measures that I mentioned. And then lastly, again, when you go to school, there's a higher risk of getting it. What is the school's response to that? That is the key, because there are success stories. So here's the success story. This literally came out yesterday, and this is from the CBC. It's a publication called Morbidity and Mortality Weekly Report. So this was over 1,000 campers in a camp in America, pediatric kids, literally from different states and actually different countries. And so they came to this camp and they implemented symptom screening, cohorting, quarantining, masks, cleaning things, and maximal outdoor programs, such that there are only 3 campers and staff who actually contracted disease. So my point is, I think the headlines become this stuff, but you have to keep it into proper context. And then in that proper context, when we implement the things that we should have been implementing, we have a very low risk of the contracting and a higher incidence of controlling or containing the virus. So in my eyes, I think about school entry as yes, I think it's possible, but I think it's also fluid. I think it's a fluid situation because, for example, it's all going to depend upon how prevalent the virus is where you live. If it's a high prevalence, it probably doesn't make too much sense to go to school. If it's a low prevalence, then it's a consideration. But a lot has to do with school policies. Are they social distancing? Are they making kids wear a mask? Are they implementing hand hygiene and personal hygiene? Are they keeping kids separate at lunchtime? And then risk assessment. What is the risk based upon your child? What's your comfort level? Certainly there are immunocompromised kids, obviously, in terms of this webinar. And so there are considerations, right? I mean, as a bone marrow transplant physician, obviously we have social distancing from the start. So our patients won't be going back to school in terms of the immediate future after a bone marrow transplant. But for those parents who actually have kids in induction or consolidation or intensification, for example, probably not a good idea to go back to school at that point. For those parents who have in maintenance and your child's doing fine, and they're actually, from a standpoint of minimal chemotherapy, I think it is possible, again, based upon the holistic picture of everything that I have here. So containment policies, what happens when a child gets sick at the school? How are they quarantining? How are they cohorting? So cohorting is another big thing. In other words, in my kids' school, they currently have gyms that they have shut down and used as classrooms. They actually have a buddy system where there are two kids who are next to each other at a desk, and they basically will then be able to identify if there's exposure, what is the social distancing of that exposure to the rest of the classroom based upon that buddy system of cohorting. So that is very important in terms of containing the virus. The other thing is testing capacity, right? Some schools rather, will have testing that is done both of faculty and staff. So again, the holistic picture is complicated, but it's complicated because the situation is fluid. But to answer this question, I do think it's possible, but there are a lot of considerations to take into consideration. So I mentioned the foreseeable future of COVID-19 or SARS-CoV-2 is in years. I unfortunately mean that. I can at least say in the next 2 years, and that has to do with it's going to take a while for the vaccine to be made and distribute, and then a willing public to receive to kind of get to that 60 to 70% mark in terms of a receptive public to have gotten the vaccine. So in the meantime, we got to ride out these waves, and that's what's going to happen. We're going to have peaks of the virus in the community, and that's where we need to think about, making sure that the community is responding with masking, with social distancing, with only going out for essential goods, without these parties and without a lot of aggregation of people, because that's what's going to spread the virus. No one's perfect, right? And we all want to see friends and family, but we do have to be mindful of what that means and how we could potentially spread the virus to family members. And so with regards to that, we have to be, or all of us, and not just for COVID, must have some sense of social responsibility, right? And that's where it gets into, the response of, I don't care, I'm just going to do what I want to do, doesn't help. It only makes things worse. It only creates the second wave. So a lot of things will remain closed during these times. Certainly, unfortunately, sporting events and going to a packed stadium will not be the case. Our kids will definitely have to be vigilant in terms of going to school, and social distancing, unfortunately, is going nowhere. But the way to contain the virus and ultimately eradicate it are these public health measures. So in conclusion, some take-home messages. The first is stay informed, right? Stay informed by webinars, stay informed by good websites. I don't mean to disparage Twitter or Facebook, but I also want to keep them in their context. You definitely want information from reliable sources, the whole point of that. Adhere to the CDC recommendations, wear a mask, social distance, stay at home, wash your hands. Can't go wrong with that. Respect the virus, right? We went through all of the attributes of the virus that make it in the driver's seat. So we have to respect the virus being in the driver's seat. Seek medical care based upon your child's needs. I really want to emphasize that. Right next to me is our hospital. I truly mean this. I think the hospital is one of the safest places. And why do I say that? Because I, as an employee of the hospital, have to self-screen. In addition to that, if I'm positive on a self-screen, I don't even come to work. The second thing is, in our hospital, all kids who get admitted to the hospital get tested. So we already know if they're positive or negative. The third thing is, in order for our kids to get a procedure like an LP or a bone marrow harvest, they again get tested. So we already know if they're positive. And certainly there's symptomatic testing. So really, the incidence in our background of our hospital is less than 1% for asymptomatic surveillance. So it's pretty safe. And then, yes, there's always a risk of nosocomial, in other words, getting an infection from being in the hospital. But again, with everything that's implemented so far, knock on wood, it's been very favorable in terms of a low, if not zero, of that. So what I'm saying is, your child's untreated disease is a bigger risk to him or her than COVID. I really mean that. So go and get your child checked when he or she has any issues with regards to their underlying cancer, for example. So continue performing good health practices, right? Get your family and your child immunized. I still think that the SARS-CoV-2 vaccine will be safe. The question again is immune response, just like it is with influenza. You won't get influenza from the vaccine, but the question is efficacy based upon an immune response. Voice your concerns, don't be silent. Voice your concerns to healthcare providers and to teachers. Look into, my child is immune compromised. What does that mean in terms of school? Seek advice from people and don't be silent. And lastly, in order for our society to get back to normal, we have to make some sacrifices. We have to mask, we have to test, we have to track cases, we have to contain the virus, and ultimately we need to vaccinate in order to be successful. So I thank you for your time and your attention, and I'm happy to take questions.
Wonderful. We've had a lot of questions streaming in, so this will be great. I think we can allot about 10 minutes to questions with our time together. So we have a question from Amy Beach. She says, my son's school is reopening under a hybrid model, like many are. The school district has stated that they do not have time to clean, disinfect, or sanitize the desks between classes. Don't desks fall under a high-touch surface, and should they be cleaned for all students?
Yeah. So Amy, my kids, I've got 4 of them. One is off to college. I've got 2 in high school and 1 in grade school. So the same principle in the sense of we also have a hybrid model. So with regards to that, I think that hybrid model basically means our school wants the flexibility so that if there are positive cases or if the background community prevalence increases, then we can switch to virtual. That's exactly what hybrid means. Sometimes they have hybrid up front. In other words, if you, Amy, as a parent feel like I don't want my kids to go to school, then certain schools will offer rather virtual classroom from the start. So just to put in that term hybrid in perspective. But you are absolutely correct. I mean, certainly desks in particular, if they are sharing them, right? If our kids go to another classroom, but that's the key. I think I would ask that. I would say, ask them, are they going to stay in the same classroom in the same desk? Now, that's not to say, then don't worry about the desk, but it decreases the amount of exposure, right? Because it's your child. The other thing, of course, is bringing wipes and having your child, depending upon how old they are, right? I get it if they're in kindergarten, but if they're in 4th or 6th grade, they can potentially do it. And it's also your personal means and be able to afford those things. But I think it all boils down to doing the right thing and asking the right questions in order to make the most informed decision.
Great. We have another question as it relates to school from Melissa Davis. She says, my daughter has been out of treatment for 7 years. I'm not worried about her actually getting the virus. I am more worried about the long-term effects of the virus mixed with possible long-term effects of chemo. Do we know anything about long-term effects in children?
Yeah, Alyssa, great question. And the answer is no. Simple answer, no, right? Because we're just, this far in the pandemic. And so we have no idea in terms of long-term effects with regards to people who actually have had COVID-19. The one thing I would say that we probably have a good idea about is the higher the severity, the greater the potential for long-term side effects. What do I mean by that? Like organ function, for example. Like those patients, those adults who have been on ventilators, or even kids, if they've been on ventilators, there's an increased risk of pulmonary dysfunction after being on a ventilator. If they were on dialysis, then there's a higher risk to their kidneys. So that's all we can really say at this point is those who have had a higher incidence of disease severity have a higher incidence of potential longer-term side effects. But we certainly can't say that there's a relationship between COVID-19 and pediatric cancer with regards to a positive long-term side effect at this point.
Great. The next question is from Krista Binns. Our community has a low transmission rates and schools will likely reopen with proper protocols in October. However, our county also has rec sports for all ages, which are currently in session and kids are playing on mask. I wonder how to weigh not only what is happening at school, but also outside of the school in the community and other homes.
Yeah, Krista, great point. So I think that this gets back to all the benefits of school. I equally am a believer in all the benefits of physical activity for kids, right? I mean, you learn about what it means to be a team player. Your kids aren't playing videos all the time, right? They're getting physical exercise, socialization in terms of sports, learning about being a leader. So all those benefits, I'm a firm believer in. So now the answer to your question is, how do you balance that? So if outside of the classroom, they aren't doing the same thing as inside the classroom, I think a lot has to do with the sport, right? Look at professional sports right now, golfers, there's not much, with regards to physical contact. Baseball, in terms of the position, not much. Obviously football is a higher incidence, more contact, soccer, potentially a higher incidence. So I think it has to do with the sport. But I think ultimately it's weighing the risk and the benefits. I didn't quite catch it, Kim. Did she say they aren't or they are in the recreational sports implementing the same as the school?
They are continuing to have recreational sports,
okay.
Even though the school may not.
Okay.
The community is.
Yeah, so the other thing is, I don't know if it's all that feasible to wear a mask when you're running around, being very honest. But I think that those principles of before they go to practice, there should be asking, symptom tracking, or rather symptom screening. That coach should say, before your child comes to this practice, you got to take their temperature and make sure they don't have any symptoms. If that's the case, then come to practice. I think, those types of implementation of those public health measures can still happen in terms of recreational sports. So a long answer to your question, I would say that, again, you have to measure risk versus benefit, but probably benefit outweighs risk in the context of those bullet points. Low viral incidence, good public health measures being implemented.
We have a great question from Maria Gonzalez Jackson. It kind of goes back to the vaccines. With the trials in phase 3, will the 30,000 number, is there a representative population of people of color?
Yeah, that is a great question. That is something that the vaccine companies are actually having a harder time getting people of color to actually want to participate. So that actually was a recent news article out of Pfizer, actually. And Maria, that's a great question, because we know that COVID-19 in minority populations has more severity than it does in white populations. And why is that? Is it because they have less access in terms of where they're living, or is it because they're congregated more because of lower socioeconomic status, or is there something physiologic that has to do with being in a group of color? Those are still unanswered questions, but yes, COVID-19 is definitely more severe. But with regards to the question, that Pfizer is definitely having a hard time getting a mix of people of color to participate. And a lot of times that, again, has to do with lower socioeconomic status. Those people can't physically get to the vaccine center, right? If they do, it's 5 bus rides that I have to do in order to do that. So the onus is on the the pharma company to figure out how to do that. Go to them, or actually allow them to have like cab vouchers, for example. But great point. And the answer is that people of color right now are underrepresented in certain vaccine trials.
We have a question from an undisclosed attendee. It says, the St. Jude COVID registry shows about 20% of COVID patients being severe or critical cases. This seems high, especially given your account that most cancer kids have mild cases. Are you familiar why with the registry shows such a discrepancy?
Great question. So, and I want to put registries into context, and that is you only have a numerator, you don't have a denominator. In other words, you only have people who have responded to the registry with cases, but you have no total number of kids. So registries are limited by that type of data. It's limited by the data the registry receives and the thoroughness of the registry in terms of data. So with the St. Jude, I'm very familiar with it. It has to do with, are there underlying preconditioning symptoms or conditions rather for those kids? Where are they in their therapy? Are the vast majority of these kids in induction, or these kids with bone marrow transplant? So that's where you have to think about the registry. So yes, you're exactly correct, but it's almost like a recall bias. I don't know recall bias, but response bias. A registry is only as good as the responses it receives, and you have no idea of the total number. So yes, it may be 20% for that registry, but for the thousands of kids with pediatric cancer, that percent probably dramatically decreases.
Great. Our next question's from Catherine Gustafson. She says, if our kids are somewhat protected from the hyperinflammatory response, are they more susceptible to the impact COVID has in other organs like kidneys, especially when their kidneys are being challenged by many of the meds they are taking for treatment?
Mm-hmm. Great question. The short answer is we don't know. Again, what we can go back is by at least what's published in immunocompromised kids. Those kids who have been receiving immunomodulatory therapies, chemotherapies, immunosuppression, yes, that immunosuppression can affect their end organs, but we're not actually seeing a spike in terms of end organ damage in those kids who then get COVID on top of it.
And then Laura Baker is asking if you can define what you consider low viral percentage in urban communities.
Yeah, that's a tricky question, right? Because when we think about any percent, it's all based upon that numerator denominator that I'm saying. So 9% means 9 out of 100 people. So when we think about the cases in America, right, we said there was roughly, I'm going to go back to the slide, 5.8 rather, 5.8 million cases in America. So there are roughly 365 million of us in America. So despite there being 5.8 million, numerator over denominator, it's still a low percent that actually have COVID. The issue, though, is the fatality that is associated with that percent of patients. So it's very hard for me to make a direct answer to that question, right? Because in the end, we know that minority populations have an increased risk of disease severity. So we'd want that percent to be even lower. So what are we willing to accept a percentage to be? Well, as a physician and a caregiver, we obviously I want that percentage to be as low as possible. So that would be my answer. I know that's kind of a shallow answer, but truthfully, we know that there are increased risk of disease severity in people of color. So we should have less of an acceptance of a positivity rate in those patients or those people.
Wonderful. And I think that our time is limited now. And again, we thank everyone for the very engaging questions. We're going to send it over to Jonathan Agan for a few final words. And again, we will get your questions over to Dr. Auletta and hopefully answered and back to you as quickly as possible. Thank you. Jonathan?
Thanks, Kim. And thank you for everybody who joined today. And Dr. Auletta, thank you for that presentation and your attempt to provide some type of guidance in an area where there is very little guidance and we just don't know what we don't know. The takeaway for me, aside from the points that you put on the screen, Dr. Auletta, as somebody in the childhood cancer community, is that we do a good job of putting information in the hands of the members of the community. And there's a lot of different organizations out there that do it quite well. And that's the good news. To the extent that the information doesn't exist, I think the comfort level that we can provide as part of this community to the members of the community is that even if we don't know something, just saying that and communicating that clearly is more comforting than having people going on Twitter or Facebook or finding places with misinformation. So my takeaway is that as a community, we will continue to try and put together informative presentations with experts such as Dr. Auletta. This is a great group of organizations on behalf of the Max Cure Foundation, Scott Kennedy and Solving Kids Cancer, Kim Buff and Momcology, Rhonda Ryan and Friends of Karen. We thank everybody for joining us today. If your question didn't get answered, I'm sure that there'll be an opportunity to try and get those questions answered. Hopefully I'm not putting anybody else up to any more work, and the recording will be made available sometime shortly. Thank you all very much. Let me turn it over to Scott to close us out, or anybody else.
Rhonda,
Yeah.
would you like to say a couple words
Yes.
about some resources as well?
Yes, I would just like to direct everybody to the Friends of Karen website, where we have a resource page for COVID-19 anxiety and stress for families who are not only dealing with cancer and life-threatening illnesses, but COVID on top of it. So you'll find a lot of, I think, really good resources to help parents with coping, to help them help their children. There's some really good mindfulness exercises and articles to read. There's an anxiety stress workbook that is amazing, and it's in 7 different languages. So I would just urge you all to take care of yourselves, because as we know and research shows us that when parents are coping and have a healthy mindset, their families functioning better, and children's quality of life improves. So I think it's really, really critically important for everybody to take that seriously, because it's a really stressful time, especially for our families that are dealing with their children with cancer. So I can't urge you enough to look at the website, Friends of Karen. And if you have any questions and want any advice from any one of our staff, we have social workers, art therapists, child life specialists on board to answer those questions. Send us an email, and we're more than happy to help you navigate this really challenging time. And I want to thank everybody for this wonderful presentation. Thank you.
Thank you, everybody. We'll follow up with the email for the archive link, as well as our best at getting the questions that were not answered answered by the presenters that we had today that we're so pleased to have. Thank you very much. Be well.